Good evening. I'm Dr. Maryam and Neama, Head of Medical Imaging Department at Farwaniya Hospital. Today, I would like to share with you our experience during the COVID-19 pandemic. I have problem in scrolling the slides.
Yes.
The objective of my presentation is to relate the changes in our department's workflow according to the government's announcements, which were based on the WHO recommendations. A quick overview of the hospital of Farwaniya Hospital. The hospital serves a population of 1,250,000 with a bed capacity of 840. And during the peak, there was more than 6,000 visits to the dedicated COVID casualty, out of which 2,500 patients were tested positive. The number of ICUs were increased from 2 to 5, and the number of COVID wards were increased from 2 to 12 accordingly. I would like to divide the pandemic into 3 phases. Phase 1, where the WHO announced the COVID-19 outbreak in Wuhan. Phase 2, where the COVID-19 became a pandemic. And finally, Phase 3, that correlate with our government announcement to gradually return to normal life. So once the outbreak started and the cases appeared outside Wuhan, our hospital called for a meeting to set a protocol in anticipation of spread of infection worldwide. They, at first stage, re-emphasized training on hand hygiene as a first line to prevent cross-infection among health workers, as well as training on personal protective equipment, which was arranged by the Infection Control Department. At the same time, triage of all patients was initiated at all hospital entrances and at the department entrance. The temperature was taken, and a questionnaire was filled, which included questions related to recent travel to infected area or contact with infected cases. Any suspected walk-in patients was not permitted to enter the department and was sent to the casualty, and suspected casualty cases were performed in an assigned room. At that time, the hospital administration started preparing 2 wards initially for the expected upcoming cases. Moving on to phase 2, where the COVID-19 became a pandemic. The government announced that all government and private establishments would be closed with exception to few areas, like Ministry of Health, and Ministry of Interior and Defense. Subsequently, a COVID team was formed by the hospital, which included the medical imaging department. This team was responsible for orchestrating the action plans within the hospital according to the evolving events. At the same time, the department management team met more frequently to assess and solve any emergent event. So our department made relevant changes in the workflow to optimize services given to the COVID and non-COVID patients, and on the same time ensure safe environment for our staff and patient. So the first modification done was reduction in the staff capacity to 30% according to ministry rules. And as you see in this slide, the difference between the original rota of daily activities and the modified one. This modification allowed us to form multiple groups of doctors and technologists who would be able to cope with the new situation. And the staff was divided into COVID and non-COVID teams in fixed groups as seen in the attached schedule. Members among these teams are not allowed to move from one group to another. The COVID team were responsible to provide care for all COVID wards, casualty and ICU, and their number was evaluated continuously and increased when required. Due to reduction in the staff capacity and following ministry rules, all elective outpatient imaging were cancelled, and a text message was sent from our RES and back system to all appointed patients, informing them that their appointment would be rescheduled later on. Yet there is a time-sensitive procedures where for patients whose imaging cannot be delayed, and they were arranged by an appointed radiologist in collaboration with the referring physician. This practice is similar to what is presented in this article, which was released on April by the University of Washington. The cancellation of the outpatient imaging had a significant impact on our workload. And as you see in this slide, there was more than 50% reduction in the total workflow during the last 5 months compared to 2019. So we keep imaging the urgent and inpatient cases, which included COVID and non-COVID patients. Therefore, new arrangements were done for the imaging COVID patients. Triage of examinations requested for urgent non-COVID related conditions were done, but non-urgent conditions were postponed till the patient was cleared. At the same time, the positive cases were highlighted on the hospital's information system so that our COVID team would be alerted, and at the same time, the wards were directed to call ahead prior to receive any patient. The COVID patients were imaged in clearly labeled, dedicated COVID CT room, cleared from unnecessary equipment for ease of infection, and also a dedicated portable X-rays and ultrasound scanners were provided in all COVID wards, casualty, and ICUs. Now moving on to the measures taken to ensure safe environment. We continue our triage process, but with more restrictive measures. So only one companion was permitted per patient if required, and surgical masks were and still are mandatory for everyone entering the department according to ministry rules. Full PPE was provided for the COVID team, and the PPE training on doffing and donning was ongoing. And other measures taken to ensure safe environment was emphasis on social distancing throughout the department by modification of seating in waiting area and in staff room, as well as for floor labeling in the reception, cancellation of daily morning meeting, limitation of access to staff room, requesting all technologists to disinfect their shared rest stations, and requesting all radiologists to use their own workstation and sterilize them after each shift. And in reference to multiple articles seen in this slide, the radiologists were encouraged to utilize remote reporting to limit unnecessary staff exposure. Of course, imaging rooms and portable units post-COVID were disinfected, and our radiology casualty was disinfected thoroughly after each shift. During that phase, the department was faced with several challenges related to lack of resources and staff anxiety. The lack of resources due to the result of the fact that we were asked to cover newly designated COVID areas, including multiple fields hospital like Kuwait Field Hospital in Mishref area and the Hospital Fields Hospital and other quarantine districts, and also newly allocated outpatient clinics. Staff infection contributed also to reduction in staff and resources. To solve these problems, rearrangement of workflow with other departments was made. So the ICU team was asked to arrange their portable chest X-rays early in the morning, where the workload is less. Also, medical team were asked to arrange fixed times during the day for their portable X-rays. The operation theater team was asked to operate only one room, alternating between orthopedic and urologist, so that only one technologist would be assigned there. Preventive medicine was so helpful in prioritizing clearance of our quarantined technologists to expedite their return to work, as well as the hospital administration relocated our quarantined technologists following their clearance so that to other accommodation so that prevent infection again. Our colleagues in other radiology departments was so helpful in responding to our request to loan us extra equipment to be used in the newly designated areas. The other challenge faced was alleviating staff anxiety, and this was done by taking multiple measures, which included that the department's management team did daily rounds on the staff and the new issues were addressed in weekly meeting. Also, updates of policies, rules, and regulations were communicated on regular basis, redistribution of the workload among the teams, and also staff who were concerned about infecting their families were moved to other accommodations arranged by the hospital according to our request. The symptomatic employee were requested to stay home and obtain an appointment through the health worker clinic to do the PCR testing. This clinic was established early on in the pandemic, and staff who tested positive were isolated according to Ministry of Health guidelines. Also, staff anxiety was alleviated by provision of psychological support for quarantined COVID positive staff, as well as application of strict measurements all through the department. Moving on to phase 3, which correlated with the government announcement of their plan to gradually return to normal life. So at the beginning, the staff capacity stayed at 30% initially to maintain safety measures and social distancing. The gradual increase of staff capacity was made according to demand. And at that period, there was reopening of outpatient clinics in 2 areas, the quarantined areas and the hospital itself. Therefore, the outpatient new appointments were given based on reduced booking of cases per modality per day to implement social distancing and allow for room disinfection, as well as elective outpatient imaging for patients from quarantined areas were postponed to the middle of second phase of the government's plan, and also the home quarantined patients were given appointments after clearance. Patients with previous appointments were remotely rescheduled at their request through WhatsApp messaging, which was posted on the hospital Instagram. We canceled or replaced the common waiting area by dedicated modality waiting areas to reduce overcrowding and to monitor patient flow. The fixed COVID-19 equipment and imaging rooms were kept, and we continued the examination triage and all safety measures. Of course, weekly evaluation of the workflow schedules was continuously done, and daily rounds to ensure implementation of safety measures were made. And currently, 80 to 100% of department staff capacity and activities, as well as scheduling of examination, all examination varieties, was resumed. So in conclusion, radiology departments must adapt to new situations, share their experiences, learn from them so as to be prepared for future outbreaks. Collaboration with other departments contributed to our success. Thank you.